Thank you for taking the time to watch our encore presentation of medical review findings in infusion services. I would like to provide some clarification regarding items that are not separately payable with infusion services. In the presentation, I mentioned that E&M code 99211 is generally not payable unless other separately identifiable E&M services are provided, and in that case, you would use modifier 25. The example here should have been that E&M code 99211 is not separately payable with infusion services. This code would never be allowed with a modifier 25, regardless of the situation. However, other E&M service codes represented by codes 99212 to 99215 could be considered for coverage and separately payable if the documentation supports it as separate and distinct and the modifier 25 is appended. Please enjoy the remainder of this encore presentation.
All right. Thank you for joining us today for this event on medical review findings in infusion services. My name is Mary Sue Gardner, and I'm a registered nurse on the Provider Outreach and Education team. And I'm going to be your facilitator for today's event. And I'm also joined today by Jennifer, who is another nurse on Provider Outreach and Education, as well as a representative from our medical review department. And they're going to be helping with the question and answer and the chat portion of today's event. So just a few housekeeping things as we get started. On our website, wpsgha.com, we have a training center. Hopefully this is where you all went to get registered for this live event. So in our training center, you have access to training materials, you have the ability to register for upcoming events, as well as access our encores, so the recordings of our live events for around 60 to 90 days, right from our website. So we post our most recent encores to our training center, and we have a built-in YouTube player, so you can watch these events without ever even having to go into YouTube. These encores, again, generally are available on our training center page for around 60 to 90 days, but they're always available on our YouTube page until we make more current information that replaces it. To find our training center, you would go to wpsgha.com, and then you're going to click on the tab that says Training Center from the top navigation, and you'll be able to find our live events page. If you have any feedback about your experience today, we would love to hear it. There's going to be several opportunities during this presentation and at the end of this presentation to take our survey. And Jennifer has placed a link to our survey in the tab for you. If you're listening to the encore of this event, watch for the survey link to pop up at the top of the screen at various points throughout the event and at the end of the event. And there'll be a link in the description of the encore. So the CMX Qualtrics survey is your opportunity to give feedback on our event. And we want to know about your experience with this event. The survey is your opportunity to not only tell us about your satisfaction with the event, but it also allows you the opportunity to tell us what additional education you want us to provide in the future. On your screen right now is a CPT code copyright notice. We have to show you this and let you know if we do have CPT codes that we will be referring to in our presentation. And then our disclaimer. And our disclaimer basically says, you know, we prepared this tool or this material as a tool to assist you as our provider community. But the Medicare rules often change. So it's your responsibility as a provider of Medicare services to make sure you're following the most current laws, rules, and regulations as they stand the day that you are providing those services. We're going to give you answers to questions based on the regulations and facts as they're given today. So again, Medicare rules have the final coverage determination. We do ask that you do not audio or video record this event. If you should happen to be audio or video recording or screen sharing, we ask that you don't. We're actually doing that for you, and we will post it to our Encore page of our in our training center and on our YouTube page. All right. Just a list of acronyms and abbreviations that I may possibly say or use during the course of this presentation. The biggest one being chemo for chemotherapy. Hopefully everyone understands that. But if I use an acronym or abbreviation that's not listed here and you don't know what it is, please just type it into the chat and someone will answer that for you. All right. Woo! So my overall objective for today's event is for you, our provider community, to gain some invaluable insight that empowers your practice to make sure that you are compliant with infusion services. And I really hope to accomplish this today by, we're going to briefly review some Medicare coverage rules as they pertain to some of the most common issues. We're going to discuss the essential documentation requirements, and we're going to dive into some of the specifics of recent medical review findings. So we're going to also analyze medical review findings and how to avoid those. So we're going to do this kind of in a unique way, and where we're going to talk about the coverage criteria, the documentation, the most common questions, and these things all pertain to the biggest issues and findings that our medical review department is seeing on review of infusion services. So let's start talking about infusion services. And infusion services refer to the process of delivering things like medication or nutrition into the bloodstream through an IV catheter. So there's 3 types of infusions that generally can be given to a patient. There's chemotherapy and other highly complex drugs or highly complex biological agents. There's therapeutic, prophylactic, and diagnostic injections and infusions. And then finally, there's intravenous hydration. And we're going to review a few of these as we move on in the presentation. So chemo administration coverage. The term chemotherapy includes the highly complex drugs and highly complex biologic agents. So chemotherapy administration codes apply to parenteral administration of non-radionucleic anti-neoplastic drugs. Also anti-neoplastic or chemotherapy agents provided for the treatment of non-cancer diagnoses. And then there's some other substances such as certain monoclonal antibodies or other biologic response modifiers. Anti-anemia and antiemetic drugs given to cancer patients by infusion or injection are not billable as chemotherapy administration. So again, let's talk a little bit about the coverage. These infusions, in order to be covered, require a few things, like a physician or other qualified healthcare professional that's monitoring, because the incidence of severe adverse patient reactions are typically greater. So again, with these types of medications, there's potentially a greater risk of adverse reactions. So there needs to be qualifying oversight by that physician or qualified healthcare professional. Typically, these infusions require advanced practice training or competency for the staff who provides the service. So if it's a nurse administering the infusion, the nurse has to seek out special training usually. There's advanced practice training that needs to be done, typically with these types of drugs. These infusions generally require special considerations during the preparation, dosing, and disposal of them too. So that's generally included in some of this additional competency training of how to handle these drugs, how they're prepared, who can prepare them, how the bags can be disposed of, etc. Unlike something like a bag of lactated ringers, which a nurse can generally pull off of a shelf, plug into the IV machine, it runs, you can unplug it, you can dispose of that in the normal means of disposal. So with chemo agents, you know, it's different, it's more complex. So some of the documentation. This slide kind of lists some general overall documentation for chemo. There are always additional things that you can and should document based on the type of chemo that you're administering. So like common signs and symptoms of infusion reactions for that type of drug, known or potential issues that you must monitor for with that type of drug or biologic, etc., things like that. So each agent can have some additional documentation that should be made based on the agent that's being administered. But overall, the general documentation that would be expected with all agents includes what's listed on the screen. So we need to know what agent is being administered. The primary reason for the encounter, it needs to be related to the chemo administration reason. Only one infusion code can be billed, initial infusion code, unless you have two separate IV sites, and that documentation supports that. A medication administration record that includes your infusion start and stop times or total infusion times for all agents that are being given via IV. If you think about the infusion itself and the administration, think about what other things you're doing when starting and stopping those drugs and make sure you are documenting those. Like, for instance, you're checking the port or the site when you're starting and stopping the medications. You should be noting any difficulties of administration or signs and symptoms of infection at the infusion site, etc. Those are just some things that come to mind. This comes in with your monitoring, but it's all the things you should be considering and remembering to capture in your documentation, which will help ensure that you also have some other means of knowing your start and stop times. So let's say, for instance, you happen to forget to note on your medication administration record the start or stop time, but you have notation of what the port site looked like at the start and the stop, and you have documented time, you know, when you observe this. So then you have the availability or the ability to go in and potentially make a late entry that contains accurate start and stop times of your overall, or I should say, or overall infusion time. So just some things to keep in mind. All is not lost by saying, you know, you missed your start and stop time. If you have other things documented that allow the person that was administering the infusions to go back and make a late entry if that's feasible. So as we move on, and we'll go back and talk about that a little bit more, you know, as we start talking, or as we talk about start and stop times. Also, you must remember that these times are used to bill specific administration codes. So if you can't prove the infusion lasted at least 16 minutes or maybe 91 minutes, we can't support the use of time codes in a lot of cases. So that's, again, how your documentation is playing into the overall review of the services. And an issue that we, often experience a lot of problems with. All right, so physician or non-physician practitioner order for the medication Infuse. The non-physician practitioner would be if it is allowable in your state, if they are able to make those orders, within your state regulations as well. Then we're going to look for evidence of frequent monitoring during the infusion. And we often get questions about what do we look for frequent monitoring. So let's talk about this just a little bit more. So monitoring can be supported by documenting a lot of things. You're documenting the IV site checks, how the IV site looks. You're taking the patient to the restroom. So when you're taking the patient to the restroom, you're asking them, how are they feeling? Are they feeling stable? Are they feeling weak? Blah, blah, blah. You're kind of doing a little walkie-talkie assessment with them. And you should be documenting that too. If you're calling a physician about the infusion, about any infusion difficulties, any vital signs that you are taking. There's no set number of times per hour or anything like that Medicare says you have to be monitoring or you have to document on. There may be internal policies or procedures in your facility on this, and there may be policies and procedures written by the drug company about how often these things may occur. So those you would need to follow, but that is not a Medicare requirement. That's a requirement within your facility or by the drug company. So while we're looking for, or some of the things we're looking for is, how is the patient tolerating the infusion throughout the infusion time? Are you checking in with them? Are you monitoring for any signs or symptoms of intolerance of the drug, et cetera? All of that is evidence of frequent monitoring. So as we move on to evidence of billing physician or non-physician supervision of the chemo infusions. So some of the things, the evidence of physician or the qualifying health practitioner supervision can be supported by the physician or qualifying health practitioner. They document that they were readily available during the chemo infusion. The nurse documents the physician or qualifying health professional was readily available during the chemo infusion. There's an attestation indicating that they actually did supervise the chemo infusion. A provider schedule supporting that physician or qualified health practitioner, was on site and readily available during the chemo infusion. So things that aren't going to support this supervision are things like the physician signature on the infusion documentation alone. So say that the physician didn't walk by, sign it, and they were gone, not anywhere in the infusion area again. Documentation indicating that the infusions were provided incident to the physician or qualifying health professional without indicating that the physician or qualifying health professional was readily available. And another thing, like a signed order for a chemo agent without indication that that person is readily available. So as we move on, we're going to talk next about hydration, because that's one of the other issues in infusion services, one of the other infusion services that we have issues with. So CPT codes 96360 and 96361 are intended to report hydration IV infusions, which generally consist of prepackaged fluids and electrolytes, like your normal saline, your D5.5, but are not used to report infusion of drugs or other substances. So these are just fluids for hydration. There's generally little to no special handling of these that needs to be done. So it doesn't require advanced practice training like would need to happen with chemotherapy. So an RN can hang hydration fluids, but doesn't need any additional advanced training outside of their registered nurse training. And that's because there's minimal patient risk with the hydration fluids themselves. So hydration IV infusions typically require direct supervision for the purpose of consent and safety and oversight by the supervising staff. So these codes are not intended to be reported by the physician or other qualifying healthcare professional in the facility center. In the facility setting. Ooh, getting tongue-tied today. All right. So let's talk about the documentation for IV hydration. You'll probably notice that I did not include general coverage criteria for the therapeutic, prophylactic, and diagnostic infusions. And that's because since the last webinar that we had, which was December 2023, we've not had any additional issues with these type of infusions. But let me just reiterate that those types of infusions, they typically also require direct supervision as well for any and all purposes of patient assessment, the provision of consent, safety oversight, and intra-service supervision of the staff. And typically such infusions require special consideration to prepare, dispose of, or dose those drugs, so there's a little bit extra preparation that goes into it, but not necessarily at the level of the chemotherapy agent. They also require practice, training, and competency for the staff who administer these types of infusions. And they do require periodic assessments, like with their vital signs monitoring as well. So the coverage requirements are pretty much the same as the chemo coverage requirements. So as we go through and we talked about the documentation, I just wanted to kind of reiterate that again. All right, so moving on with the general documentation requirements when it comes to IV hydration documentation. And we pretty much covered these through chemo, but, I'll just kind of go through briefly. Again, for all types of infusions, the things we're going to look for at and upon medical review are the medication administration record. And that medication administration record needs to indicate the start and stop time or the total administration time, as well as physician orders for the infusion, any policies or protocols that are developed by the institution that detail guidelines for the hydration infusion, if there's any guidelines or protocols or policies on monitoring. We want to make sure that you as a facility are following your policies and procedures as well. So you would need to submit those. Again, general documentation requirements, and I kind of got my cart before my horse, and so we've kind of covered all of these as well. So as you can see, as we go through the documentation of any kind of infusion services, the general documentation for all of them are pretty much the same. Only one infusion code is reported unless you have two IV sites. Again, that was the same for therapeutic prophylactic, and it's the same for chemo administration as well. So now we're going to, in these next couple of slides, we're going to cover some of the most frequently asked questions as they relate to findings and how you can avoid having these questions in the future. Because these are questions we get asked by our providers, especially when they get a denial of services. So again, in an effort to help you not have to ask these questions, let's answer them now. So the first and probably most questioned issue is on infusions, has to do with start and stop times. And how long, what do you do if you don't have the documentation, et cetera. So first, infusions that are not hydration, they require at least 16 minutes of time to be billed as an infusion. To be billed as an infusion, I'm sorry. If you do not have at least 16 minutes of time, it could be considered an IV push, whether that's therapeutic, prophylactic, chemotherapy, etc. The same with hydration. To build that initial hydration code, you have to meet the time requirements as well. And the hydration requires at least 31 minutes of time. Again, so what happens if there's no documented start and stop time and no total infusion time? What do? You bill the service as an IV push, if you can bill it as a push. Also, like I had stated earlier, look at your documentation to see if a late entry can be made by that healthcare provider. Do you have documentation to support the pre-infusion assessment, the post-infusion assessment, the vital signs that were taken right when you started the infusion and the vital signs that were taken at the end of the infusion? Just like we talked about when, we were talking about chemo. So if you can make a late entry into your documentation, which again, you have to follow your state, your facility rules for things like late entries. But if you can make a late entry, that's great. If you happen to forget start time, stop time, or total infusion time. But if you have nothing to support, your start and stop or your overall infusion time, unfortunately, you will have to bill as an IV push if you're able to do that. Okay, another question we get asked is, what do you bill if your infusion takes longer than it was ordered? So this will be dependent on what the infusion is for. Let's first talk about hydration. If you have an order to run 1,000 mils of lactated ringers over 30 minutes, however, due to the site, the gauge of the IV catheter, whatever the case may be, the person's blood vessels, the infusion of the LR takes 65 minutes. What do you bill? So if the initial hydration is ordered to run 30 minutes and it takes 65 because of those factors that we discussed, then you bill for the time it took to run the infusion. You can bill initial hydration in this case because it was longer than 30 minutes and up to an hour. Again, remember to check time frames of how long the infusion took, and then check that against the requirements for your initial infusion. All right, the next question is always on infusion hierarchies. So those are laid out on this slide. When reviewing whether infusion services were billed appropriately as initial or subsequent, use the following hierarchy that I have on this page for you. So the infusion hierarchy for billing is a system for coding and billing infusion services that determines the order in which to bill the service and the number of units to bill for each. So in this case, chemo has priority over therapeutic, prophylactic, and diagnostic services. Therapeutic, prophylactic, and diagnostic services has priority over hydration. Infusions have priority over IV push. IV push has priority over injections. So remember, the duration of the infusion determines the number of units to bill for each service. So for example, 91 to 150 minute infusion is considered 1 unit of additional subsequent service. So you'd have your initial service and then you have an additional subsequent service if you've moved into the 91 to 150 minute category. And then if you then have 151 to 210 units or minutes of infusion, then it's considered 2 units of the additional subsequent. Also remember, only 1 initial code is allowed per patient encounter unless you have 2 separate IV sites and unless it's medically necessary. So if an infusion crosses over the next day, bill it with the date that the service was started on. When coding services, consider the following questions. Why is the patient here? What did the patient receive? How was it given? How long did it take? So infusion hierarchy for non-facility. So using those same principles that we just discussed under facility hierarchy, let's move into the non-facility. First thing you need to consider in non-facility, what is the primary reason for the visit? So the purpose of the visit and the type of treatment being given. And this is going to help you decide where you are in the hierarchy. Then you start consideration of what infusions trump what. So just as with facility, it goes chemotherapy, then therapeutic prophylactic, and diagnostic, then hydration is the lowest. So infusions themselves trump pushes. Pushes trump injections. So the next question, what did the patient receive? Was it chemo, non-chemo, hydration? Again, then you move through the infusion hierarchy like we have listed here. And then again, was it an infusion, an injection, sub-Q, IM, etc.? All right. So now let's talk about some of the billing limitations for chemo and non-chemo infusions. And of course, this continues to play into some of the issues and findings that we have. Keep in mind, I mentioned this before. You can only bill an initial code once per patient encounter. The only exception to this is when the patients have 2 separate IV sites or if the patient leaves and returns for another medically necessary encounter on the same day. If you have an instance where you meet one of these exceptions, then you must append the appropriate modifier for 2 separate and distinct services, and this would generally be your 59 modifier. All right. So in keeping with limitations for chemo and non-chemo, if a physician or other qualified healthcare provider is reporting the service, then the infusion services should be provided in a physician's office or a non-facility setting and are not in a facility setting. So infusions in an ambulatory surgical center or ASC, which are related to another procedure, are not separately payable. All right. Finally, infusion services performed as a standalone service in an ambulatory surgery center or ASC, those are separately payable. So hopefully you got that. If they are related to another procedure, are not separately payable. If they are standalone in an ASC, they are separately payable. All right, the next billing limitation, which we also have questions on, is billing limitations for hydration. So you don't report hydration codes when the purpose is to keep a vein open, like prior to or in between therapeutic infusions, or when the fluid is being used as free-flowing infusion, just being given during chemo or other therapeutic infusions. Also, don't use hydration codes when hydration fluid is administered as a concurrent infusion. And finally, remember the rules of hydration services performed in a facility center. So again, infusion services in the ambulatory surgery center related to another procedure are not separately payable, but if the infusion itself is standalone, they are separately payable. All right. And then initial hydration services is another question that we get about the billing. The 96360 can be billed when hydration is the only service provided on the date of service under review. So for example, the patient presents to the emergency department and it's noted, that patient's noted to be dehydrated. And the physician then orders 2 liters of normal saline to be administered over 4 hours and 4 milligrams of oral Zofran for nausea. It is appropriate to bill the 96360 because there's no other IV medications that were given. However, if other IV drugs or substances are given, it is not appropriate to bill the 96360. So the 96360 is used to represent hydration infused for 30 minutes or greater. Subsequent infusion hours are then billed with the 96361. So as we move on to the 96361, remember your hierarchy here. So when any other drugs or substances are given on the date of service under review, hydration is billed with a secondary or subsequent code, and that's the 96361. So we'll go back to that example. The patient presents to the ED, noted to be dehydrated. The physician orders 2 liters of normal saline to be administered over 4 hours and 4 milligrams of IV Zofran for nausea. It is not appropriate to bill the 96360 because another IV medication was given. So the Zofran is appropriately billed with an initial code and the hydration with a secondary code. When hydration is billed as a secondary or subsequent infusion, the 96361 can be used to represent the hydration infusion of 30 minutes or greater. So just note, this is only when the 96360 is not applicable. All right. And then let's talk about, we'll continue with some of these billing limitations that we often get questions on. Some other billing findings when items are not separately payable. So if any of these items or services listed here are performed to facilitate an infusion, then they are not separately payable. So this includes things like the use of local anesthetic, IV access, access to indwelling IV or subcutaneous catheters or ports, flush at the conclusion of an infusion, or the standard tubing or syringes and supplies. Also, the E&M code 99211 for office or outpatient visit to evaluate and manage an established patient is generally not paid separately here unless other separately identifiable E&M services are provided. So remember, you can't double dip. It has to be separately identifiable. If that's the case, then it can be billed, but it would have to be billed with the 25 modifier. All right, continuing with the not separately payable, and I know we're getting close on time here, so I'm going to speed things up just a little bit. When fluids are used to administer drugs, then the administration of the fluids is considered incidental hydration. And again, that's not separately payable. And we've kind of talked about that before, but it comes as a part of the separately payable questions that we get. Also, when non-chemo infusions via IV push or infusions in an inherent part of a procedure, like the administration of contrast material for diagnostic imaging, those are not separately payable then as infusions because they are part of that procedure. All right. And then some infusion time requirements. So let's talk about hydration. Hydration first, because the time frames are a little bit different. Anything under 30 minutes of hydration cannot be billed as an initial hydration infusion. So remember, chemo and non-chemo drugs, that's 15 minutes, but hydration is 30 minutes. So in order to bill the first hour of hydration, that infusion needs to run 31 to 90 minutes. Again, that's why it's so important to document your start and stop times, your total infusion times, because we use these to make sure your codes are appropriate. The time frame then for additional hours then remains pretty much the same. So the 91 to 151 would be 1 unit. The additional hydration code when we go from 151 to 210 would be 2 units, etc. And and that would just kind of cover the information on both of these. So I talked about hydration first, but I should have been talking about chemo first. But again, remember the chemo and non-chemo drugs, you have to have at least 15 minutes. And then as you move on with the hydration code, that has to be at least 30 minutes. And I'm sorry I kind of get fast on my clicking, but that's because we're running to the end of our presentation. So on your screen is just some additional references where you can find the information we used in preparing this education for you today. So just in recapping really quick, and you don't have this slide in your slide decks, but I always like to do a recap. So today, my objective for you was to learn about these latest MR findings in the infusion services. And really we accomplished this today by going over that coverage criteria, documentation requirements, discussing what's not being followed, the things that are coming up in medical review as frequently asked questions or frequent issues. We analyzed some of that medical review finding and used that to talk about how to avoid those issues and really discussing those common questions. So we achieved our objective for today. What I didn't achieve is allowing time for questions and answers. And I do see that there are a handful of questions in the chat. So in the interest of time, what I'm going to do is formulate the answers to those, and I will send that out via email to all the people that participated. So you know what questions came in and how we answered those. I also have some pre-submitted questions that did come in. Most of them pertained to the things that we actually talked about today. But I did formulate some answers for those, and I will send those out as well. So I'll leave a little bit of time up. You can continue to put additional questions in the chat if you would like, and I'll make sure when I send those out to everyone that I answered those as well. So just in the interest of time, we're going to move on, and on your screen right now, following this event, you're going to receive an email that looks pretty much like this information on the right-hand side of the screen, and it's going to be proof of your attendance. This email contains your contact hours if you need that for continuing education. It's also going to have a link to our survey, and we'll discuss that a little more in the upcoming slides. If you only joined via phone, I do need you to send your phone number and an email saying that you participated to wps.gha.education@wpsic.com. Let me know your name and your phone number, and I will send you out a certificate of participation, because you're not going to get an email if you weren't signed on via computer or tablet, or, you know, that way, if you only called in. If you think of any additional questions regarding this event, please email those to us at that same email address and send them within the next week. Please don't send any PHI or PII. And remember, we don't have access to those claims processing systems. So if you need to find out something claim specific, you do need to take those questions to customer service. After the webinar is complete, again, you're going to get that email with your certificate of completion. And then finally, as I stated at the start of this presentation, we value your opinion. We want to hear from you on how we did. Jennifer's going to place a link to that survey in the chat, which I see she already did. The survey really only takes a few minutes to complete. So we do ask that you do complete it. This is our opportunity to hear from you. Let us know what you think about our educational events, as well as giving you the opportunity to let us know what additional information you want in the future. So if you want more information on this topic, please take that survey, let us know, and we do a lot of educational events based on that survey feedback and the information that you say you want. All right, on behalf of Jennifer and myself, as well as Medical Review, we want to thank you for your participation in today's event. I will be making a document with those follow-up questions. I will send it to you within the next several days after we get all of the information compiled into one document. So this concludes our webinar, and you may now disconnect.